Good afternoon, everyone, and thank you for joining us. We see everybody coming into the webinar. We're just going to wait a few minutes for everybody to join before we get started. Again, for those of you who are just joining, we're waiting a few more minutes and then we'll get started, but we're almost at 100, so thank you all for being here today. Okay, it's officially 2 o'clock and we've got just over 120 on the call and hopefully more filtering in as well. So good afternoon and thank you for joining us for today's webinar, Starting the Conversation, Perinatal Mental Health, hosted by the Provincial Council for Maternal and Child Health, otherwise known as PCMCH. My name is Brittany Groom. I'm a program manager here at PCMCH and I will be moderating today's webinar. It's an incredible opportunity that we have to hold the time and space today for the next hour and a half to talk about perinatal mental health. And I thank each and every one of you for coming, for your presence and participation in today's discussion. The title of the event is Starting the Conversation, and that's what we're doing today. We need to start the conversation. We need to get comfortable talking about mental health, initiate these conversations to screen for mental illness in our perinatal patients, and ultimately ensure that this population does not fall through the gaps or any cracks in the healthcare system. I would like to begin by acknowledging the land on which PCMCH operates. This land is the territory of the Haudenosaunee, Wendat, and Anishinaabe people and is governed by the Dish with One Spoon Treaty. This nation-to-nation agreement committed these nations to share the territory in peace, friendship, and respect. All newcomers are symbolically included in this treaty and in the spirit of these obligations. Today, Toronto is home to Indigenous peoples from across Turtle Island. We recognize that PCMCH's members and stakeholders are located on traditional Indigenous territories across Ontario. I encourage every participant to reflect on the land you're on, who the traditional keepers of that land are, and what the treaty relationship is, or if it is unceded territory. For those of you who may not be familiar with the Zoom webinar platform we are using today, you can utilize the Q&A tab at the bottom of your screen to ask any questions throughout the webinar. However, we will be holding any responses and answers on our end until the end. The webinar is being recorded today, just so you're aware, and that recording will be available afterwards on our website and through our social media channels. And if you're experiencing any technical difficulties during the event today or have anybody you know who is unable to join, please send an email or a message in the chat to my colleague, Tracy Morris, Program Coordinator at PCMCH. If Tracy, you want to wave? And finally, we have a few poll questions today. Your participation in those polls is completely voluntary, but I assure you that they are completely anonymous on our end internally and what you view on the outside. So to get started with that, we want to get a better sense of who our audience is today. So a pop-up is going to appear on your screen. If you could please select the most appropriate answer. And if the most appropriate answer is other, feel free to type some more context or additional information in the chat box. Good. We'll just wait a few seconds for everybody to put their vote in. Can everybody see that? Thumbs up. Great. So what is your profession? We've got 50% nurses, are registered nurses or registered practical nurses in the audience. We've got midwives here. We've got physicians, nurse practitioners, psychologists, social workers, and others. I know that there are so many healthcare provider categories and very specific types of within all of these categories, but we just wanted to get an initial sense. And I can see some responses coming up in the chat now as well. And a second quick poll for you. In which area of the healthcare system do you primarily work? We've got acute care, or hospital-based, primary care, home and community care, public health, education, research, and government policy or other. Again, keeping in mind that these are large categories, and I know there's a lot of very specific healthcare workplace settings. So we have a great mix. Hopefully you can see that on your screen. We've got about 21% from acute care and hospital, 18% primary care, 12% home and community, 33% public health, 8% education and research, 2% government policy, and 7% other. Again, if you're falling under that other category and you feel comfortable, please share what that might be in the chat so we can capture that. It is now my pleasure to introduce our speakers and presenters for today. These individuals all have extensive clinical and research expertise in this area and on this topic, and their contributions to perinatal mental health cannot be captured in a brief bio introduction. So I encourage you to seek out their scholarly work, their websites, their social media, if they have it, and their organizational affiliations to find out more about their many contributions. But nonetheless, in brief, we have Dr. Simone Vigod. Simone is the Chief of Psychiatry at Women's College Hospital and professor in the Department of Psychiatry in the Faculty of Medicine at the University of Toronto. Simone also holds the Shirley A. Brown Memorial Chair in Women's Mental Health Research at Women's College Hospital. Dr. Cindy Lee Dennis is a professor in the Faculty of Nursing and Faculty of Medicine in the Department of Psychiatry at the University of Toronto. Cindy is also the Women's Health Research Chair at Li Ka-shing Knowledge Institute at St. Michael's Hospital and Fellow with the Canadian Academy of Health Sciences. Jamie Charlebois is the Regional Perinatal Mood Disorder Coordinator at Aurelia Soldiers Memorial Hospital. And Jamie is also the co-founder and research director at the Canadian Perinatal Mental Health Collaborative. And Christina Canton is a perinatal consultant with the Champlain Maternal Newborn Regional Program. And Christina is in her second year of her PhD in nursing program at Queen's University with a research focusing on perinatal mental health. So without further ado, I'd like to hand it over to Simone.
Thank you very much, Brittany, and thank you for the warm welcome. I am so pleased to see almost 200 participants here today, and I'm going to start. I've been tasked with starting to build the case about why it's important that we have a perinatal mental health pathway in Ontario, and I suspect, given that everyone who is here, that you have already been convinced, but I will do this anyway. So perinatal mental health, what is perinatal? We have really, I think most people would agree that we've started now in this field to think about perinatal in the months even leading up to the conception of a pregnancy, as well as during a pregnancy, and then in the time afterward. And, I think while there are many different definitions of, when the postpartum stops and ends, I think generally we're thinking about, people at least in the 1 year after delivery when the issues that they're experiencing are related to hormonal changes in the transition to parenthood and or the managing of an infant. Although, as I think we would all agree, the line between what is postpartum or perinatal and then moves off into parental can be somewhat blurry. We have some statistics here up on the slide talking about, the 1 in 5 experiencing perinatal mental health issues. It is the case that the vast majority are common mental health issues related to anxiety and depression, possibly anxiety even more so than depression, and included in that obsessive compulsive disorder, intrusive thinking, as well as a growing acknowledgement about post-traumatic stress disorder, either related to something that is recurring from an earlier experience or related to the birth itself. Of course, severe mental illnesses such as bipolar disorder or schizophrenia, as well as substance use disorders, can of course occur. And when we think about Canada as a whole, there are about 400,000 births in Canada every year. So 1 in 5 is 20%. So we're talking about, 80,000 pregnant postpartum dyads of, parent and baby and their families affected each year on an annual basis. And what you can see here is a graph that came from Public Health Ontario, just about people in Ontario reporting maternal mental health concerns during pregnancy. And you can see a creep up over time from maybe around the 15% mark to closer than the 20% mark. And whether that means that the prevalence is increasing or that people are more inclined to disclose it, regardless, we're sitting somewhere in the 1 in 6, 1 in 7, 1 in 5 range of people affected. Why does this matter? Of course, if we have untreated mental health issues around the time of pregnancy, that can affect severely the quality of life, physical well-being of a pregnant or postpartum woman or person. And if untreated, that can then become chronic and affect them for a long time to come. We also know that this is a period of time where a person's mental health not only affects themselves, but also can affect another being, either the, the growth and development in pregnancy, attachment, etc. after delivery, which can have impact on children's social and emotional development. So there are so many reasons why we want to prevent these concerns from happening in the first place, and why when people are struggling, we want to get them better very quickly. While severe outcomes like suicide are very rare, because we live in a country where maternal death is rare, a very high proportion of the deaths that do occur are related to mental health issues. And a number of years ago, a group of us published some research showing that in Ontario, suicide is one of the main reasons why a person might die in pregnancy or the year after delivery. In addition to that, not everyone is equally affected. So while risk factors for perinatal mental illness may include biological ones, like a personal or family history of mental health issues, or social support issues or life stressors, we do know that there are various groups related to inequities in health structures and related to systemic racism. There are various groups that may be more impacted, either by mental health issues themselves, or impacted by not having appropriate and inclusive access to care to either prevent or treat perinatal mental health issues. So next slide. A couple of years ago, Statistics Canada did a very quick snapshot survey to see where we were at across the country. And although this wasn't a diagnostic measure, they did use, I believe they used maybe 5 questions from the Edinburgh Postnatal Depression Scale score, just to get an idea of whether people were reporting any symptoms of anxiety or depression. And overall in Canada, it was actually above the 1 in 5 mark that were reporting any such symptoms. And you can see Ontario is right at the national average. Next slide. And this is information reported in the Better Outcomes Registry Network, which any of you that are providers in Ontario, you would be filling these out. This is the clinical registry that you're filling out on behalf of your patients. And so this is what providers are recording their patients having reported as mental health concerns in pregnancy. So you can see that a lot of anxiety, a lot of depression, and in addition, histories of postpartum depression and other illnesses. And remember, this is most likely an underreport, because this would require that the provider asks and the person discloses. And so there are multiple steps here that would take it to make it into this data set. Next slide. And I think, we would be remiss, we did start the work for this when we did not really understand what kind of an impact the COVID-19 pandemic was going to have. But it became clear very early on about the heightened stress around being pregnant in a pandemic. There was a survey that came out of researchers in Calgary who showed that it may have been as many as a third to a half of pregnant people were reporting, at least high levels of psychological distress. Some work from our group, we were able to look at service utilization over the course of from about March 2020 till November 2020, and we saw consistently increased contacts with the healthcare system in Ontario for perinatal mental health issues. And so, I think there are many reasons why the COVID pandemic has probably had the impact that it has had on mental health around the time of pregnancy, including fears about infection, pregnant people getting more ill, concern about infants being infected, but really the whole social and health structure, including, visiting public health nursing programs, having grandparents, having baby groups. When I in my clinical practice am talking about, what do we do to prevent and treat common mental health issues such as anxiety and depression, it's really about being with people, getting help, having appropriate social support, validating, those are all the things that we want to do before we're even starting to talk about psychotherapies or medication therapy. And I think the COVID pandemic has really removed, for some time a significant, number of those structures, and it's been going on a long time. So, while, there have been some amazing initiatives with virtual care and everyone has coped the best they can, I think we are for some time going to have this sort of group or cohort of parental child dyads who are going to need our help. And so, what's the state of where we're at? Next slide. So most of you are probably aware that the Ontario Perinatal Record does have some questions for case identification of mental health issues. And so you can see them here. You can click off, past or current mental health and substance use problems. There's the generalized anxiety disorder scale 2 and the depression patient health questionnaire 2. And it's really been shown that using one of these, even though they're really short, can really be used to case identify and see, you know, does this person need something more? And then as well, the Edinburgh postnatal depression scale is also in the Ontario perinatal record. So as we thought about, you know, what to do in the go forward, you can go to the next slide. We really thought about, you know, what do we already have in Ontario, including the perinatal record, including much of the public health nursing system, you know, which has been thinking about this for a long time. And how do we think through, you know, from case identification all the way up to matching people to what they might need, whether that is peer support in the community, whether that is support with a public health nurse, whether that's psychotherapy or whether that's needing to talk to someone about medication. How do we think through, using best evidence of what we know works, how do we work through a process of helping Ontario providers get their patients what they need when they need it? And, you know, and doing this in the context of, you know, quite a lot of, you can see here, quite a lot of variability. This is a national survey that the Canadian Perinatal Mental Health Collaborative, which Jamie hopefully will speak about a bit later. We'll talk about how do we do this in the context of, you know, almost 90% of people reporting that they don't really have a mandated way of case identifying for perinatal mental illness, and you know, 60% reporting they really don't have specialized training in perinatal mental illness. So I will turn it over now that I have identified the problem for you to Dr. Cindy Lee Dennis, who will talk to us about the solution.
Great, thank you, Simone, for that great presentation identifying the gap that we have in clinical care and the need for a solution to address this long-standing clinical problem of perinatal mental illness. And the solution that we have worked on is a care pathway for the management of perinatal mental health. Next slide, please. The objective of this care pathway was to build healthcare provider understanding and awareness of the delivery of perinatal mental health services across the province of Ontario, so that it was standardized and it included a step-care approach, and that it didn't depend on where you lived as to what types of services that you would get, that there would be a basic level of care that was equitable across the province. And we wanted to help these healthcare providers to identify individuals who required additional care, and then to help them direct these individuals to a care pathway that was most likely to be beneficial for them. And this was depending on their level of symptomatology, so whether they had mild symptoms all the way up to severe and urgent symptoms. But we also wanted to make sure that this care pathway took into consideration treatment preferences, which could include cultural and gender preferences. Next, we wanted to make sure that we had a follow-up part of this care pathway. This monitoring or follow-up part is really, really critical for any screening or early identification program to be effective and to improve both short-term and long-term clinical outcomes. You need to have a follow-up plan. So for these screening programs or identification programs to improve outcomes, you need to first be able to identify individuals accurately who may have the condition that you're trying to target. And then you need to be able to give them access to timely treatment or some sort of intervention that will change that care trajectory or that treatment or that condition pathway so that you can change the outcomes. And then you want to be able to follow up to ensure that they are that they are for sure engaging with the healthcare recommendations that you are making. So that's where the monitoring comes in. So they engage with the referral pathways that you've recommended, that they are actually responding to the care so that whether their symptoms are getting better, which is what you want, or potentially their symptoms are getting worse. So then you want to direct them to additional resources or different types of treatments. So again, the objective of this care pathway was to help individuals identify those who require care, to direct them to appropriate care pathway, and then to monitor and follow up symptomatology to remission. Next slide, please. So how did we develop this care pathway? Well, the first thing we did is a comprehensive literature review of all the different types of clinical guidelines that were already developed. We didn't want to reinvent the wheel here, but we wanted to build upon years and years of expertise and the development of previous care pathways, from those that were developed in Australia to the UK to out in British Columbia and such. So that informed the development of our Ontario-specific care pathway. We also turned to the Perinatal Mental Health Toolkit that was developed for public health units across this province. This was developed by the Healthy Human Development Table that was co-chaired by myself and Andrea Feller, and it was supported heavily by Public Health Ontario. We developed this toolkit because we did a survey of all the public health units across this province, and we knew that different health units were using different tools to identify women with perinatal mental health services or issues, that they were providing different types of services, they were using different types of cutoffs to refer people to different types of services. So it was various and it wasn't standardized at all. So with this toolkit, we helped provide a care pathway that could standardize the provision of care in the public health realm. But we also need to understand that to comprehensively address perinatal mental health, that it can't just be based on the services provided by public health, that we also need to engage primary care practitioners, we need to engage midwives, family physicians, we need to engage obstetricians, pediatricians, and such, because perinatal mental health issues can occur across the continuum up to 1 year postpartum and thereafter for many individuals as well. So that's the literature review that we did to inform us with this care pathway. We then had a stakeholder consultation where we showed the care pathway to subject matter experts. We had 2 focus groups with various experts. We took their feedback and modified the care pathway. We presented this care pathway multiple times to PCMCH committees and received their feedback. We consulted with experts with Ontario Health, the Mental Health and Addictions Centre of Excellence, and the Ministry of Children, Community and Social Services. So we had various stakeholder consultation and many opportunities for individuals to provide us with feedback, and we modified accordingly. And then we used the data from the Born Registry to help guide the preferences that we used in this document in terms of common mental health conditions. Next slide, please. So to make this care pathway user-friendly, we took a 5-step approach. The first step is to ask. And this is asking the woman who is presenting in front of you at every visit, her current situation, how is she feeling, what's going on with her at home, and such. This asking is really critically important because you can be detecting the signs and symptoms of depression or anxiety, but also looking for non-specific difficulties, such as what's happening in the home and relationship issues. Those types of issues can be risk factors. And with that, we want to move on to step 2, where we can talk to them about the prevalence of postpartum depression and risk factors and what things that they can do to protect their mental health in the perinatal period, so during pregnancy and the postpartum period. So education is really important part of step 2 and the advised category we've outlined here. We then move on into step 3, which is where we do a detailed assessment of these individuals to determine the severity of symptomatology. We've outlined 4 different levels of symptomatology, from mild to moderate to severe, and then we have the 4th, which is urgent care. And we have aligned each one of these assessments with a treatment step, which is step 4, to assist these individuals by recommending and implementing a treatment step. We used a step care approach where individuals with mild symptomatology would go into step 1, That's where the bulk of the services will be provided, or where women will land. But then we have a step 2 where we have more moderate symptomatology, and we'll talk a little bit more about what that entails, all the way up to severe and urgent. Step 5 is the arrange, and this is where we will, at the end of our 5-step process, have a care plan identified for these individuals, where we make referrals to appropriate services. We have agreed upon treatment goals. We have an agreed upon treatment follow-up plan, and we have confirmed contact information for the individuals who will be providing the treatment. So there's a way to access the treatment. There's a way for us to follow up to ensure that these individuals are following our recommendations and receiving the care that they require to address their symptomatology. Next slide, please. So what does this care pathway look like? We've developed, we call it a 2-pager to increase the clinical utility of this. We didn't want this huge onerous document that people had to have on their desks to help guide them in the provision of managing the perinatal mental health condition of the mother in front of them. So what we did is, with this 2-page document, on the first part has our 5 steps. And then on the second part, so page 2, is the 4 different treatment plans that we've outlined. So right now, what I want to do is just go through this 2-page care pathway that we've outlined. I just also want to highlight to you that we do have a guidance document, a 40-page guidance document, which will provide a lot more details for you if you have any questions regarding these 5 steps or the treatment steps. So for this care pathway, number 1 is ask. So again, we've already talked about that, where we want to assess their psychosocial well-being. We want to see what's going on with them at home, and to see what type of factors may have that might increase their risk to develop postpartum depression. Step 2 is the advising. Again, we want to educate the family about perinatal mental health, the prevalence of it for both depression and anxiety. And then we also want to link them to some community resources to let them know what's available if they start developing a few little symptoms. And we'd like to have some counseling. So that's the Healthy Babies, Healthy Children program. We've got live links in this document. So you can use this document to have it on your computer or some electronic system, or you can have it as a 2-pager that's laminated that can be sitting on your desk. If it is electronic, we've built in live links into this care pathway. Step 3 is the assess for the severity of the mental health condition, and we've combined that with step 4, so you can see that there's a way that you can just monitor from the assessment all the way to what does that mean in terms of scores and severity of symptoms. So with the assessment, we've outlined a different group of tools that could be used very rapidly in the clinical situation. You can have the GAD-7, so that's the Generalized Anxiety Disorder tool with 7 items to assess for anxiety. And then if you want to assess for depression, we've included in the guidance the PHQ-9, which is 9 items. That's the patient health questionnaire. That's often used in primary care, and we've included the cutoffs for that for mild, moderate, and severe. And then, of course, the EPDS that all of us are very much familiar with. We've included the cutoffs again for mild, moderate, and severe symptomatology. And so for mild, we've color-coded it as blue, and we've aligned that blue to the treatment path of 1 when you flip it over. So you can see that it's very easy to follow this guide. And for mild symptomatology, this is just a few but persistent symptoms that have a minimal impact on day-to-day function. For moderate severity, we've outlined that there are some symptoms that are persistent, but it's impacting the day-to-day function and the quality of life of individuals. That would align up with step 2. For severe, these individuals have severe symptoms. You can see the cutoff scores for the anxiety measure and the 2 depression measures. And it has these individuals who have these types of symptoms have significant impact on their day-to-day function and quality of life. And this would align up with treatment step 2 or 3 based on symptomatology and, of course, client preferences. And then step 4, in terms of treatment plan, that would be based on urgent types of symptoms that we would see. So these are individuals who have symptoms of psychosis or mania or risk of self-harm to self or others, or it would be a positive score on the PHQ-9, that's item number 9, or the EPDS, the item number 10. These are individuals who not only score positive, but also have an intent or plan for suicide. So these are individuals that need immediate care. And then once we've assessed them and put them into a treatment step based on their symptoms, then we arrange the follow-up with them. And that's outlined there, where we look at the how often we want to follow up with them, how will we follow up with them, and such. Next slide, please. So this is the second page of the 2-page care pathway that we've outlined here. So step 1, that's aligned with mild or subclinical symptoms, or these are people that you might want to just watch and wait and just see how they're doing at the next visit to see if the symptoms are worsening or whether they're improving. And step 1 would be aligned with psychosocial interventions or community type of support. We've outlined here some interventions that would be aligned to this type of symptomatology, and that would be self-help materials such as self-directed workbooks for depression or anxiety. We also have outlined guided self-help, which is internet or paper-based self-guided interventions that may include assistance from a trained coach. An example here would be Bounce Back Ontario. In terms of peer support, it would be any type of community resource where there would be the provision of mother-to-mother support, such as Life with a Baby, or we have supportive counseling, which could be provided through Postpartum Support International, that's PSI, or the Healthy Babies, Healthy Children program by Public Health. So that's treatment step 1. If they do not have mild or subclinical symptoms, but have worse symptoms that are growing across time, we can put them into step 2, or they can go directly into step 2. So you don't have to start with step 1 and move through the different 4 steps. You can come into this treatment plan at any point based on symptomatology. So if they can go into step 2 if they start with symptoms that are moderate to severe, or they have mild or subclinical symptoms that are strengthening with time or worsening with time. Step 2 is your psychological interventions, where we often have self or healthcare provider referral. And in step 2, we also include antidepressant medications. The types of interventions that would be aligned with step 2 would be cognitive behavioral therapy, or CBT, or it would be interpersonal psychotherapy, or IPT. And an example would be Mothers Matters. It's an online therapist facilitated discussion board and therapy group for postpartum depression and anxiety. This is free for anybody across the province of Ontario, and this is Simone's program at Women's College Hospital. It's an excellent program that she's evaluated and has been shown to effectively improve clinical outcomes for women with depression and anxiety. We also have the Beacon Digital Therapy, other different types of internet-based cognitive behavioral therapy that is free in Ontario, outlined here through links. Additional resources that could be used in treatment step 2 would be Postpartum Support International, 211 Ontario, or Connex Ontario. These are databases that provide access to different types of online mental health resources that would be available. In terms of medication, and then of course, when we talk about medications within the scope of the primary care provider, antidepressants can be used when psychological interventions alone are not sufficient, when symptoms are severe, or that there's a patient preference to take antidepressant medications, and that could be because they used them effectively previously, or that this is something that they want to try now to quickly have symptoms resolved. And then if we can move on to step 3, which is additional specialized interventions. And these are for individuals with severe mental health concerns, or again, is for individuals who had the moderate to severe symptoms that did not recover in step 2, and now we're moving them up to step 3 because of that monitoring part of the 5-step process that we've outlined previously, where we want to monitor these individuals and follow up with them to see how they're doing in our current step plan that we've outlined for them. So for step 3, the types of interventions that we're looking at here is provider to psychiatrist e-consultations for support around treatment recommendations. So this is the Ontario Telemedicine Network. We also have, you can also consult with public health units in Ontario to look at what type of patient-provider consultations are available in their particular jurisdiction. Additional resources that are available are the Canadian Network for Mood and Anxiety Treatment. This is an online resource that can outline different types of evidence-based treatment that would be available for individuals with this type of severe mental health concerns. Step 4 is treatment for individuals who we suspect might be having mania or psychosis, or they disclose an intent to harm themselves or their infant or someone else. And so this is a real emergency. It happens very rarely. This is a requirement for urgent care and immediate assessment and potential hospitalization. It's really important to understand that many pregnant and postpartum women do have intrusive thoughts of harming themselves or harm coming to their baby, but with no active intent. So we have to make sure that each provider will have a different level of comfort with this assessment, and that we make sure that they take their clinical judgment into consideration when caring for these individuals that we suspect might have these psychosis or thoughts of harming themselves or their infant. If the provider is concerned about mania, psychosis, or harm to others, they can initiate a plan to transfer this individual for emergency psychiatric assessment. Physicians can complete an Ontario application for extended assessment, which is the Form 1, the Mental Health Act. We've included that in the guidance at the very end in the appendices. They can also call emergency services to ensure safety of this individual. So these are the 4 different types of treatment steps that I've just very briefly outlined. The types of interventions that could be delivered for these individuals based on the symptomatology level. The guidance provides a little bit more details about these treatment steps. Next slide, please. So this is the guidance that I've talked about. It's 40 pages, and it can be downloaded and saved as a PDF, or you can have an automatic link to this. We're constantly updating this guidance so that you can have access to the most current types of resources that are available and evidence. Next slide, please. And one last point that I'd like to make, as I've quickly outlined this care pathway, is that we do not include preconception care in this care pathway, but to understand that ideally we would optimize management of any perinatal mental illness or individuals who are at risk for a perinatal mental health illness or have a significant number of risk factors. We would want to optimize their management prior to pregnancy. Types of preconception care management strategies that one could incorporate can include preventative strategies such as optimizing health behaviors such as nutrition, physical activity, sleep patterns, and screen time and such. We can promote a supportive environment for that individual, whether it's with their partner, with their extended family, or for them to be aware of the community resources that are available for the provision of extra support. We can review with them current or previously used psychological and pharmacological interventions that were beneficial or were not beneficial, and to highlight what could be used if they have a developing a new episode in the perinatal period. And then we can engage treatment with them to reduce the risk for relapse. So this would be if they currently have symptoms or they have a significant number of risk factors, and use this treatment as a preventative or secondary preventative type of strategy. Preconception care, I know it can be difficult to deliver, but it is part of the Ontario Public Health Standards, and it's something that we should be considering. Preconception care is easy to deliver if you think about the fertility rate here in Canada, where on average women have 1.7 children, so 2 children. So if they have 1 child, they typically go on to have a second child. And if we look at the child spacing data, we know that they often have their second child 24 to 36 months after the first child. So a great opportunity to provide preconception care and to address the mental health needs of individuals as they think about planning to have a second child is to target families that just had a new baby. So then not only can you provide perinatal mental health care to individuals with the first child, but use that as an opportunity to provide preconception care for another child if they're planning to have a second or third child within the next 24 to 36 months. In terms of pharmacological management, there is a role for that preconceptionally. This is an opportunity for you to talk to them about if they currently are on antidepressant medications, whether they want to continue or discontinue during pregnancy, and whether they want to take it while they are breastfeeding. This would require a decision-making approach with an expert to help them balance the benefits and risk of medication use. So next slide, please. So with that, I'd like to pass it on to Jamie. That is a very brief introduction of the care pathway. Again, more details are provided in the guidance document. And of course, we're available at the end for questions if you have any. Over to you, Jamie. Thank you.
Thank you, Cindy Lee. Good afternoon and good evening to some of our international audience members. I'm going to lead you through a couple case studies to kind of talk about the potential application of the care pathway based on my own clinical experience. The following 2 case studies are not specific and are quite broad. The goal with this exercise is to explore the pathway and its application. So our first case study revolves around Lucy, who is a 29-year-old female. This is her first baby. She has a history of multiple perinatal losses, and she lives in a well-resourced urban area with her partner. She has a spontaneous vaginal delivery at the hospital and is discharged within the normal amount of time, around 24 hours postpartum. Within the COVID-19 context, she has very limited family support. Actually, the majority live abroad, and she has an aunt that lives about 4 hours away. She has not had access to family and friends through her pregnancy, and this has potentially placed more risk to her mental health in the postpartum period. The Healthy Baby, Healthy Child program within the local public health unit receives her Hbhc screen and does the phone assessment or the IDAC within 48 business hours. When Lucy answers the phone, she is crying a lot, and she constantly is questioning her maternal ability, her parenting abilities. And so at this point, the local health unit does prioritize a home visit that occurs on day 5 postpartum. And I just wanted to note that healthcare or health units do have some variation in the response times. Next slide, please. Okay, so I'm not going to flip back and forth to the care pathway, just so we have, nice dialogue here. So the first 3 steps of the care pathway actually occur quite fluidly. And really what we're trying to do is create an environment of trust and respect. And it really is not a laborious process. Some people look at a care pathway and can become overwhelmed. Look at it step by step. So in the first step, ask, second step, advise, and assess. I've kind of brought them together to make it a little bit more manageable. So Lucy presents day 5 postpartum to her public health nurse with low motivation and low energy. She has overall sadness and is crying quite easily. The public health nurse notices that there are quite a few issues related to breastfeeding, especially with the latch, which is having a direct impact on her mood. And she is quite exhausted. So even in her presentation, she isn't very well groomed. She hasn't had a shower, and she has quite dark circles under her eyes. The public health nurse goes forward to do an EPDS, and Lucy scores an 18 on that assessment. There is a 0 response to question 10 about thoughts of self-harm, so no suicidal or homicidal ideation. So we are day 5 postpartum. The public health nurses realize that this is potentially baby blues, potentially an adjustment disorder, and according to the care pathway, based on her EPDS score, this is moderate symptoms and severity. So the public health nurses provide lots of validation and reassurance, which is so needed in these early postpartum days. They speak to Lucy about what perinatal mental illness is. What are the risk factors? What are the prevalence in her area? And really understanding what the symptoms are and how they present. And then they schedule a follow-up within the next couple days. They refer Lucy to fantastic community programs such as the Early On Child and Family Center, where although she couldn't do in-person programming, she was able to connect to programs over Zoom. And she also connected with the Canadian Prenatal Nutrition Program and the Canadian Action Plan, Community Action Plan for Children, and to a local perinatal mental health specific group. And they also referred her to her primary care provider at this time. Next slide. So the next 2 steps of the care pathway is to assist and arrange. And so the family doctor was able to schedule an appointment with her on day 12 postpartum, and the full assessment was completed, and steps 1 through 3 were done again. So this time Lucy presented as tired, but overall her general mood was happy. And she did tear up at times, but she was able to get through the appointment and speak to the family doctor about her concerns with her mental health. In between day 5 and day 12, she was able to see a lactation consultant, which helped corrected some of the latch issues that she was experiencing. And her aunt came down for the weekend. Remember, it was a 4-hour journey, but this allowed Lucy to get much needed sleep. And this is why when the family doctor redid the psychometric tests like the EPDS and the PHQ-9, she scored in the mild symptom severity range. So an 11 on the EPDS and an 8 on the PHQ-9. Lucy is a very avid reader. So the family doctor presented the Bounce Back Ontario program, which does have a perinatal mood disorder component. She did some self-directed activities through that, and the family doctor followed up in 2 weeks. This is, a very basic situation, as I had said previously, but it is very common. And with this level of intervention, we hope that it can mitigate some risk moving forward. Next slide. So in our second case study, we have Faith, who is a 40-year-old pregnant individual. It is her third child, and she lives in a rural community, which is not well resourced. She has a pre-existing diagnosis of general anxiety disorder. She had been on meds previously to her pregnancy, but she was advised to discontinue those medications in her pregnancy by her healthcare provider. Throughout her pregnancy, she had complications. She met the criteria for the dreaded advanced maternal age because she is over 35. She had hyperemesis gravidarum, which is a more severe form of morning sickness and closely averted hospital admission for dehydration. And she had some structural issues with her placenta, so she had a bicornea or heart-shaped uterus. And the placental issues, there was some thinness where the placenta attached to the cord, which had to be monitored closely. So this lady, Faith, was referred to a local obstetrician because she was considered a little bit more high risk. And the obstetrician looked at the Postpartum Support International website and what we call the PSI provider directory, and found a local therapist that was specially trained in perinatal mental health and referred for severe anxiety at 36 weeks pregnant, with the goal of the therapist doing some postpartum planning and really helping Faith get prepared for her upcoming birth and the days and weeks after her birth. Next slide. So the first three parts of the pathway, Faith presented to her perinatal mental health therapist with quite high anxiety. She was having what we call what if thoughts, which are those future minded thoughts where a lot of anxiety can be generated because they have no control of those thoughts and what's happening. She had quite reactive mood. She was teary. She talked about being impatient, angry, and frustrated, especially related to work and her colleagues. And she had the physical symptomology of anxiety, which like tight chest, and she found she was quite hyperactive. The significant case history was the fact that she does have a family history of bipolar disorder and schizophrenia in a maternal uncle. Her mom herself had severe postpartum depression. And because of her severe anxiety, this does make her more susceptible to sleep deprivation in the postpartum period. And as a registered nurse, she already knows from night shifts that she does not do well when she doesn't get enough sleep. She also spoke a lot about hormonal susceptibility with her therapist, about the fact that surrounding her period previously, she was quite irritable. She was had a lot of lability in her mood, so up and down and around, very reactive. So it's possible that she met the criteria for what we call premenstrual dysphoric disorder, which makes her more susceptible to postpartum hormonal changes. So the mental health therapist does an EPDS with the client, Faith, and she scores a 20 out of 30, which is quite severe. And she is having thoughts of self-harm. So she would be a number 1 on question 10 with thoughts occurring hardly ever. She was very open with her therapist about what the thoughts were like. So a full risk assessment was completed, and Faith did not have any intent or plan, but did discuss a lot of intrusive thoughts, which were really wrapped up around the severe anxiety and thoughts about harm coming towards the baby and to other people in her life. So looking at the care pathway, she is in the severe symptoms and severity category. Next slide. So in the next 2 steps of the pathway, assist and arrange, the therapist faxed intake notes and assessment to the obstetrician asking for a prescription for an antidepressant, and sertraline, or better known as Zoloft, was prescribed. at their visit, which was the following week. And that specific obstetrician is a regional perinatal mental health champion, meaning they are, very well versed in perinatal mental illness and the resources in the community and safe medications while pregnant and breastfeeding. The therapist also put in a prenatal Hbhc referral, so to their local health unit, to start the interactions with a public health nurse and lay home visitor, so that she could be supported through the last part of her pregnancy and into the early postpartum and up to the children's age of 6. So the therapist was able to offer 3 weekly specialized therapy sessions before she gave birth, because remember, she was referred at 36 weeks, and this is quite common. So the therapist really wanted to make sure that Faith had a postpartum plan. So thinking about what her postpartum needs were, how to prioritize her mental health leading up to her birth and afterwards. And so the Postpartum Stress Center in the United States has a fantastic website. This is Karen Kleiman's domain, and she created something called the Postpartum Pact. And this therapist advised Faith to do this exercise on her own first, and then to do the exercise with her partner and the people that are providing the care to her in the early postpartum days. So the Postpartum Pact looks at, I believe, 6 domains where we're really asking the people around us what we need them to do, what we need them to say, what we need them not to say, and how to really watch this person, because many people with pre-existing mental illness know what their triggers are. And so if they're starting to feel really anxious or they're starting to feel really low mood, I need you to look out for isolating. I need you to look out for me pulling away from certain people. So making sure that that's really clear so the people around them can pick up on that quickly. The therapist also did some really simple mindfulness exercises, and on YouTube, if you type in Corey Mascara, these are fantastic mindfulness exercises. So the first one is Take 5, which is a tactile exercise with deep breathing that really helps slow and allow the person to regulate again. The next one, because she is a very anxious person, the video talks about shifting your what if thoughts to the what is. So taking those future-minded thoughts and bringing them back to what's right in front of you and what you can control. The therapist also asked the obstetrician to recommend this client for what we call the sleep support program, which is offered in some hospitals across Ontario. It sometimes is called the 5-day, 5-night, which allows people an extended stay on the postpartum unit to maximize their sleep in the days after the birth, so that once they're discharged, they go home kind of on the right foot, well rested, with reserve and coping mechanisms. This lady also had the financial ability to hire a postpartum doula, which after her prolonged postpartum stay was able to come over for several nights and continue to provide more through the night care so she could prioritize her sleep. This person also, after her birth, was referred to the Ontario Structured Psychotherapy Program, where she received cognitive behavioral therapy for generalized anxiety disorder. So once she was able to get settled and the baby was able to be cared for during session. Both healthcare providers in this situation used the QR code at the bottom of the pathway to submit their feedback in regards to the use of the pathway, and this feedback goes straight to PCMCH, and changes can be made dependent on the comments. So thank you very much for your time, and if you have any questions I can answer later, please put them in the chat. Over to you, Christina. Thank you.
Thank you so much. So we've had an amazing presentation, and I'll do a quick recap before I head into my section. So we've heard already about the prevalence of perinatal mental health and the rising rates of anxiety and depression during the pandemic. We were introduced to the new PCMCH, Perinatal Mental Health Care Pathway, and the guidance document. And then we were just provided with the patient perspective as 2 case studies were presented and reviewed. So I'm now going to talk about the knowledge translation implementations, considerations. But before I do that, I want to first thank you for being here and being part of the conversation about improving care for families who are impacted by perinatal mental health. I also want to acknowledge that we're still in the midst of the COVID-19 pandemic, and I know that you're all working tirelessly to provide amazing care and support to your patients or your students if you're in the academic setting, and you're caring for your families, your coworkers, and your communities. It really has been an exceedingly challenging time, and I'm so inspired that there's been such a great turnout for today's webinar. So I thank you for making this a priority amongst all the other competing priorities. So next slide, please. So I want to start with a story because I always want to position families at the center of our work. And I do send a trigger warning because there may be some details that are disturbing. So you can mute the presentation right now if you want, or other self-care measures. So I'm going to tell you the story of Joy Gabriel, who was pregnant, and she suffered in silence until it was almost too late. Joy was 30 years old. She was married and she was living in Queens, New York. She was 6 months pregnant with a second child, and she said, "I should have been happy. I should have been able to sit cross-legged with my daughter, building block towers and reading stories. Instead, I spent my time throwing up, pulling out clumps of hair, and cutting my arm with a knife. My husband traveled regularly, working long hours, and I was often alone with my toddler." One day, Joy recalled reaching a critical point. She walked over to the window of her apartment. She violently pulled it open and she said, "I heard a small voice say, 'Jump.' I stared at the storm outside, matching the storm within, and finally, for the first time in 6 months, I felt peace. I looked over at my daughter and I knew she needed to come with me. This voice, not a voice I could hear, but one I could feel in my heart, told me that the only way to save us was to bury us." So I'm going to pause the story right now, and I am going to come back to it end, but I just want to share the story to emphasize that the stakes are very high. So next slide, please. I want to begin by talking about the Adverse Childhood Experiences, or ACEs. And ACEs comes from a research that was conducted by the Centers for Disease Control and Prevention, which was groundbreaking public health research in the 1990s. And the research discovered that childhood trauma leads to the adult onset of chronic disease, depression, and other mental illnesses, violence and being a victim of violence, as well as financial and social problems. And since that time, there's been over 70 research papers that have been published. And I like this image because I think it captures a lot of the evidence that we have related to the ACEs. And I'll start with number 3 there, the environment. Right now, we're dealing with natural disasters. We're in the middle of a global pandemic. There's flooding. We had horrible fires, and there's a climate crisis. So we're facing that right now. Number 2 is the community level. And these are the social determinants of health that I know you are aware of that do impact health outcomes. And the conversation today is at the household level. And if you click the button next, I have 2 red circles that are talking about maternal depression and parental mental illness. So in perinatal care, we have this amazing opportunity to focus on the well-being and healthy development. And we can think of a life course intervention for the entire family, which actually has the potential to change the trajectories of lives. And so this slide here is just showing you that toxic stress can have epigenetic effects. So these early adverse childhood experiences results in disrupted neural development. And you could see the trajectory going forward about how it progresses to chronic disease, disability, and potentially early death. Next slide, please. So we need to be thinking about our healthcare system. Next slide. The ACEs, the increasing number of ACEs that an individual has is associated with the increased risk for negative health outcomes. And on the slide, there's a few listed on the left-hand side in terms of the effects on health, on behavior, on life potential. Next slide, please. And you may think that, oh, this is a problem in the United States, but it's not. We have Canadian data that is showing us very concerning results. So this was important research done by Dr. Racine and her team that looked at maternal adverse childhood experiences and infant development. So this was a prospective longitudinal cohort study involving nearly 2,000 women and their families. They found that the more adversity in childhood was associated with more health risks in pregnancy, with more infants born with health risks, and associated poor developmental outcomes at 12 months of age. And these researchers continue to follow these babies up to 3 years of age, and the results are very concerning. Next slide, please. This is an important infographic that the Canadian Perinatal Health Collaborative included in their recent report. In the UK, there's the Maternal Mental Health Alliance, and they commissioned an independent report to document the economic costs of perinatal mental health in the UK. And in Canadian dollars, you can see that the cost of one case of perinatal mental health and anxiety disorders is estimated to exceed $150,000. But with screening and treatment, this can be reduced to $5,000. So we need to do this. The economic costs alone are astronomical, and the personal suffering that families experience is extraordinary. We can't afford to not provide early intervention and support. So on the next slide, I want to share with you a systematic review that was conducted a couple of years ago. There is a statistic that I think you've heard that it takes about 17 years for evidence to be integrated into practice, but we don't have 17 years. Families need our help today. So this systematic review looked at 15 papers that describe methods for designing interventions to change healthcare behavior. And so they have identified 4 tasks that need to be completed. And I don't think the results are surprising to you, that you really need to look at barriers, you need to look at intervention components, use theory, and engage end users. The researchers found that actually there was limited evidence about how to design interventions at the organization or the system level. And so on the next slide, I'm going to focus on implementation considerations. This is the PARIS framework, or the I-PARIS framework, the integrated promoting action on research implementation in health services. This conceptual framework is useful to explain and predict why the implementation of evidence into practice is or is not successful. Implementation is multidimensional, it's complex, and we have to take into consideration context. If implementation were easy, it would have been done already. In the original version of the PARIS framework, the authors describe successful implementation of evidence into practice as a function of the quality and type of evidence, the characteristics of the setting or the context, and the way in which the evidence was introduced or facilitated into practice. There's a revised model that was proposed by Harvey and Kitson, which included many of the same construct, but there was a change to a greater emphasis on the integration of these core concepts through active facilitation. So successful implementation in the I-PARIS framework is defined as the achievement of agreed upon implementation or project goals, the uptake and embedding of the innovation in practice. Individuals, teams, and stakeholders are engaged, motivated, and own the innovation, and the variation related to context is minimized across settings. So on the next slide, you'll see the image of a continuous spiral to depict the continuous process of implementation, given that it's a dynamic process. So at the beginning or the middle of this model, there's a focus on the innovation. And today we're talking about perinatal mental health care pathway and the guidance document. Next, we go to the recipients. So that's the individual clinicians and the healthcare teams. And this was a new construct to really appreciate that these are the people who are doing the implementation of the innovation. Then we move out to the different layers of context. So there's inner context, which is twofold. So that's the immediate setting for implementation. So we have to look at primary care clinic, the hospital unit, the general practitioner's office, and then the organization in which that unit or that department is based. And finally, we come to the outer context, which is the wider health system. So these are the policies, the regulatory frameworks, and the political environment. And I know we have people from the ministry who are on the call today, and I thank you so much for being part of this conversation. So we need to progress from a focus on the more specific, concrete actions of implementation to addressing contextual factors and the barriers that are likely to influence how this is going to be implemented. So next slide. So this is a continuum that I just came up with, and I recognize that everyone is somewhere on this continuum and that many of you have already done a lot of work in this space of perinatal mental health support and intervention. But maybe it's something that you've been wanting to work on but haven't had a chance, and that's okay. So this launch might be the catalyst for action. Today, we're starting the conversation as a healthcare system in the hopes that we can create a robust perinatal mental health strategy for Ontario. So appreciating that the pandemic continues to exert pressures, I want to offer a few strategies that might help to get started on integrating this care pathway in Ontario. So the goal today is to identify a few actionable items for the short term, and then we can have more conversations in the future. Now, if you already have a well-developed program, please share the information in the chat box because we can learn so much from each other. So include your town or your city and any web links or contact information for your program. So what can you do? I would suggest that the first step is to understand your data. So I would suggest conducting an audit to determine your current rate of screening. We've heard today that the prevalence is 1 in 5, and during the pandemic, 1 in 3. So what is your rate? If you saw 10 pregnant or parenting individuals today or this week, with how many of them did you have a conversation about perinatal mental health? Could you be missing individuals? And it's important to remember that perinatal mood and anxiety disorders are the most common complication of pregnancy and can affect people of any race, ethnicity, income level, education level, marital status, or age. And that's why we need to implement universal screening. Step 2, share the results with your colleagues, maybe at a team meeting. Is this data surprising? What might be contributing to this? If your screening rates are on target, what processes are in place that help you and your team to identify individuals who might be struggling with their mental health? If your screening rates are low, what might you be able to do to increase the chance that you're able to identify individuals in need of support? And then step 3 would be look at the care pathway and determine what aspects of the ask, advise, assess, assist, and arrange are you currently implementing? What areas can you improve? What are your sticking points? Are you arranging follow-up appointments to monitor symptomatology, the acceptability of the treatment plan? Do you need to make modifications or changes to the treatment plan? And who are your current collaborators? What opportunities exist to broaden your menu of available supports? So for example, are you engaging social workers who can help with social determinants of health, such as the financial and legal aspects that people are struggling with? Are you familiar with local shelters in your area if people are experiencing intimate partner violence? Are you connected with agencies who are providing counseling and intervention for substance use disorders? So really look at the care pathway and see what you can do. And then identify an improvement goal and a facilitator who might be able to facilitate this work. So next slide. So this is just a graphic that I came up with when I was looking at the different stepped care approach. And most of the patients are going to fall in the level of benefiting from community support. And there's going to be fewer patients who need the specialized intervention, urgent care, hospitalization. And so at the next page, I'll continue the story with joy. So going back to joy, Joyce shared that she had struggled with her mood during her first pregnancy, but nothing like this. She had tried strategies that she referred to as happy tricks. She posted cheery pictures to her family blog. She went for walks outside. She cooked dinner. She kept a gratitude journal, and she drank kale smoothies, but none of it helped. She couldn't sleep. She felt anxious all day and sick from the pregnancy. And every time she looked at her daughter, she felt overwhelmed by guilt that she wasn't the kind of mother she felt her daughter deserved. She was convinced that she had ruined her beyond repair. She was about to strap her baby girl to her chest and jump out the window, but something caught her in her chest. "Help," she heard herself say. She ran to the phone and she called her doctor. And within an hour, she had a referral for a perinatal psychiatrist who Joyce said was the only person in the universe who seemed to have any idea of what I was going through. She prescribed medication, and while I was worried about what would happen to my baby if I took it, I knew what would happen if I didn't. The psychiatrist assured me that she was going to work in tandem with my OBGYN to take care of the baby growing inside of me. And then she looked at me in the eye and said, "But right now, someone needs to take care of you, because if there's no mama, there's no baby." So I was impacted by Joy's story because I think it captures the importance of what we're collectively wanting to work on. We really need to be thinking about a healthcare system that is responsive so people can get the help that they need when they need it. And we want to reduce the loss of life, which is the most serious complication of untreated mental health. But we also want to prevent suffering. So on the next slide, today's the launch officially of the PCMCH Perinatal Mental Health Care Pathway. And I really hope this spearheads conversations across Ontario and Africa, across the ocean, to talk about how we can implement the 5 A's to caring for this population. So I'll turn it over to Brittany now for questions.
Great. Thank you so much, Christina, and to all of our speakers. That was such a dynamic flow of presentations, and they all had spoke to different elements that we all can take back and resonate on after today's event. So I'd like to move right into question and answer period. And I'd like to offer any of the questions up to all the speakers to just chime in if you have a response. So I'd like to start with, and this is taking a few questions and compiling them. We have this incredible care pathway resource, and we've got embedded links within it and resources that are province-wide, some of them, or majority of them. So how do we manage the long wait lists and the need for timely access to treatment? How do the two speak to each other, and what can we do to mitigate some of those concerns with timely access?
I don't mind starting. I mean, I think it's a very complicated question. And I think, what we have here is something that we've never had before in Ontario, right? Most of the perinatal mental health care pathways have existed. Someone mentioned the RNAO best practice guidelines in the chat, the public health toolkit, but we've always had a bit of a gap in terms of what to do for the kind of antenatal care providers, midwives, family physicians, obstetricians, even the pediatricians. And so, I think there is an element of this, and, Christina said it too when she spoke, there is an element of putting this out there and saying, listen, this is within your scope. It says it within the Canadian Pediatric Society guidelines, the SOGC, everybody's guidelines say this is within your scope. This isn't somebody else's problem. And now we're giving a pathway that tells you what to do. And as Christina was saying, there's a whole bunch of stuff in that first step 1 that people and their practices should be doing. And there's a whole host of evidence around peer support, community there's a whole host of evidence, in the UK, the National Institute for Clinical Excellence guidelines, they separate things into low intensity interventions and high intensity interventions, the lower intensity ones being basically lower cost, really. And we're probably on some level not being efficient enough. It's not enough to just say, okay, someone is struggling with issues. Okay, let's put them over there on a waiting list, because there is so much. So part of me does believe that if we organize ourselves properly and get the people in the people who will benefit from the lower intensity interventions where they need to be, that will open up more space for people who need the higher intensity interventions. Now, of course, it's complicated because we probably still don't have enough of the higher intensity specialization, and we probably have, I personally think we have work to do in terms of integrating with the rest of mental health care and helping people realize that if you have a mood and anxiety disorder program, that doesn't mean that you don't do pregnant people. And so, we can be embedded in the regular, like these are adaptations, and we can be taking a little bit more of a share of the resources, given that, 50% of people are capable of having babies, right? I mean, this shouldn't be something that's off to the side. I think some of the advocacy work that's been done though recently in terms of having, it is now in the Liberal platform federally to have a strategy and think through a strategy. And I think this is a really ripe time about transfer payments to the provinces for more psychological care. And so I think there are opportunities to, there are always opportunities for education, but I guess I think we need to make sure that we don't just say, put it over here and we need more, that we all have a responsibility as a community at each level to do each level. So others on the panel may not agree with me, but that's how I see it.
If I just, Cindy Lee, if I could offer another question building off of that. This was about the generality or the generalness of the care pathway resource. And there are some questions coming in about tailoring, about diverse population groups within the perinatal population, and how could we respond to that? So the specific question is saying, are there specific resources for low income and non-English or Francophone speakers? So maybe Cindy Lee or Simone, you could speak to why the care pathway was created in the way it was, to be a very general resource, and the fact that we really do want the individual practitioners to be tailoring this to meet the patients that they are working with.
Yeah. So I'll just talk a little bit here just to answer the previous question as well, just to build upon Simone's response, and then to talk about why we left it general. First of all, I think it's really important that if we want it, we have to start thinking around prevention. Everything's so focused on treatment. And if you can prevent perinatal mental health issues, then you don't need to have all these wait times and a huge need for all these services if we just invest maybe preconceptionally and identify at-risk families and educate, advise them, and link them up with really great community supports as a first step preventative strategy. We know with a trial that I did that if we take new moms within the first week postpartum who have just a little bit of depressive symptoms, and we link them up with an experienced mom and just provide that new mom with telephone-based support, we can cut the risk of postpartum depression by 50%. So if we just think about these simple, low-lying sort of fruit strategies, things like Life with a Baby can offer as prevention, I think that would be important. So that's building up the community resources, thinking about prevention, and maybe starting preconceptionally before the family. We know that 50% of pregnancies are unplanned, but 50% are planned. And we know that a lot of prime-makers women go on to have a second child. So there's an opportunity for preconception care and preventative strategies. We developed this care pathway so that there's no longer the standard excuse that we get that they don't want to ask women about how they're feeling because they don't know what to do with women when they find that the woman is experiencing issues. That's why we kept it pretty general, so that wherever a woman is encountering a healthcare provider across that perinatal spectrum, they can fit themselves into this. Whether it's antenatally with a midwife, a family physician, or an obstetrician, or postnatally with a pediatrician. It all falls within their scope of practice. So we kept it pretty general. The service is general. And, you know, some of these more specific programs, they have yet to be developed, but they're on the radar. And these are things that we're working with healthcare providers to tailor some of these general services to make them more for the more of the at-risk or diverse population. So I think that that's one way to answer this question about inclusiveness, equity, and what about wait times and what we can do in thinking about prevention. I also just want to say, you know, these IPT services and CBT, you know, there's been several studies now showing that we can train nurses to deliver these interventions as well. So that's another way to decrease wait times. You know, it doesn't always have to go to a highly trained psychologist or perinatal psychiatrist to deliver these types of interventions. There's nurses everywhere that can be trained to deliver IPT. We published that trial. We did it here in Canada. We did it across Canada, recruiting women who are severely depressed, linked them up with 7 public health nurses who are situated here in Toronto, who are supervised by a perinatal psychiatrist. And we delivered that type of treatment very effectively. So we need to be thinking about diversity in how we provide these services and who are the providers. So that's it for me right now. I don't want to take all the time.
Thanks, Cindy Lee. Go ahead, Jamie.
I wanted to mention that in North Simcoe Muskoka, our Women and Children's Network has applied for a intersectoral action fund through Public Health Agency of Canada with the support of PCMCH. And we're hoping if we receive the funds that we will be able to do an intentional rollout of the pathway throughout our region to really help support the community to build capacity so that more treatment and more support is done to build their confidence within the community. So like Simone was saying, the people that are specially trained can take more of the more severe or moderate to severe cases. And I think it's going to be a really exciting next steps. Obviously, I'll continue the work without the grant. It's just having funds is really fantastic. But I think the piece that everybody is looking for is like, how do we take what's happening now and make it actually happen, to engage the community, to get our healthcare providers all on the same page. And you know, it's coming step by step. And we just appreciate all of you so much for attending and passing this information and pathway throughout your communities.
Thanks, Jamie. That ties in really well to one of the questions and comments that came in about how do we measure success of the implementation of this care pathway and guidance document, and what does that look like? So if anybody wants to reflect on that, really, Jamie, you touched on it in terms of that tentacles out to all of the regions, really spreading the word across the province, getting this in the hands of the people it needs to be in the hands in. And like you said, sometimes that requires seeking external resources to support implementation, and sometimes the resources actually might already be within your toolkit and available to just start small. Any comments about what success means in terms of rolling out or implementing this care pathway?
I mean, I think one of the big opportunities coming forward are the Ontario health teams and the regionalization. And I think, you know, nobody said this specifically, but it's throughout the questions, is about care navigation, right? And so with the idea that the Ontario health teams are going to have hubs, and that care navigation for something like this could be part of those hubs, right? That would alleviate a lot of the pressure, because it absolutely is, you know, if I ask somebody and they're not doing well and I don't have anywhere to send them and I don't know what to do next, then like, why would I ask, right? And so it's about setting up those structures. And so I think with all of the changes in Ontario, it's really nice that this has been done, at least to the point that it's been done with this pathway, because we have something to give them. We can say, oh, you have navigation, you want navigation in your hub, here's your template.
Yeah, exactly. Yeah.
Go ahead, Christina.
Yeah, and I'd say our experience in the region, the Champlain Maternal Newborn Regional Program in the pandemic, is that sharing information about what's available. And obviously the pandemic required a very fast shift to virtual care. And it's the communication about, what's happening, what are you offering? So that was a very valuable experience. And we probably need to do that more. It's like, what's available in our local area? People didn't know, like even in the space of mental health or people in the space of breastfeeding support in preparing to do panel webinars, like there was just this connection and this continual work that we need to keep doing to just advocate for the programs that are existing and how do the referral pathways work. So that's why I was asking the question, like if you have a program that's going on, pop it in the chat, share it with everybody, make sure your program's showing up in a searchable database like Connects Ontario. Things are changing like way too fast. You can't think of everything. We get patients and families from different areas. These are a supported database. There's funding to maintain that. And I would suggest that perhaps we need to keep using that as a starting point because we can't be aware of everything that's going on in all of our communities. So that might be something to consider as well, is just really doing a concerted effort to make sure that our perinatal mental health programming are showing up in those avenues and really sharing with our local system, family primary care providers, midwifery practices, primary care organizers, whoever needs to know, who are family oriented, supporting pregnant and parenting individuals.
Thanks, Christina. And I invite on that thread anybody who didn't get a chance in the chat box today to email us. I put it info@pcmch.ontario.ca. We're happy to be that hub, compile a lot of this, and we'll find a unique and innovative way to share that information out to ensure that it's reaching the appropriate people. So with that, I hate to say, but we have reached just past 3:30 and have to conclude. For anybody that put a question in, we really tried to get to as many as we can, but we will look through those, address anything that we can internally, and feel free to email as well if you'd like a specific answer. But with that said, your feedback is so important to us. So if you could please complete a survey that will pop up when you close this webinar browser. In addition, PCMCH is really dedicated to improving the usability of the care pathway tool. And I recall seeing a question about how this would be kept up to date, and it truly will. It is not a one-size-fits-all care pathway tool, nor is it something that we will publish and not look at again. So we're going to be continuing making sure that there are no, that the links are active, that it's being updated, that they're appropriate, and that this is something that's not just going to end after today. And we encourage any healthcare providers to submit feedback. If they are using the tool, there's a QR code right on the care pathway, and you're welcome to submit feedback through that way. And as Jamie said, that will go straight to us at PCMCH to acknowledge and improve upon. And with that said, that concludes our webinar. The recording will be available on the PCMCH website in the next week. Follow us on any of our social media channels as well if you want to stay up to date on other events or programs or guidelines in the maternal, newborn, and pediatric space. And I'd like to extend my deepest gratitude to our presenters today. Simone, Cindy Lee, you were instrumental in the development of the care pathway. Christina, Jamie have been fierce advocates in the perinatal mental health space, connecting with me, and I'm really grateful that you were here today to present. And thank you everyone for spending the last hour and a half plus with us, and I hope you have a great rest of your day.